Okay, this is Dr. Neil Cross, and this is the third lecture on cell pathology and infection, and we're going to cover cytology today. In the first part, looking at non-gynecological cytology, and then moving on to gynecological cytology. So a quick overview of what I'm going to talk about. So we'll be looking at what sort of specimens are used for both gynae and non-gynecological cytology, looking at the sample prep, the staining techniques. We'll be looking at some morphology features of some common cell types, and looking at cell block preparation, and also always comparing what cytology means in the context of what could be done, which is histopathology. However, it's clear that histopathology can really only be done where you can take a full depth tissue biopsy. In certain clinical situations that is just not possible, so a lot of the samples we'll be dealing with here will be analysed by cytology, and then if possible a follow-up biopsy will be taken, which will be analysed by histology. So as I've noted in previous lectures, particularly the histopathology lecture, cytology is the microscopic appearance of cells used in the diagnosis of diseases, usually or quite often malignancies, not always, but quite often malignancies, whereas histopathology and histology is looking at tissue. So histo, tissues, cyto is cells. And gynecological cytology tends to be centred around the NHS cervical screening programme, now moving more into human papilloma virus testing. Traditionally was very much about looking at cytology specimens on a microscope slide and scoring them that way, but as you'll hear from Fran in a later lecture, we're now moving towards molecular testing for human papilloma virus as a first test, rather than just looking at cytology. And then if those samples are high risk, and we'll define what high risk is in a later lecture, then we can go on and look at cervical biopsies, and I will cover cervical biopsies in the second half of this lecture. For non-gynecological cytology, we're looking at things like urine or sedimented urine, fine needle aspirate biopsies, or just fine needle aspirates, and we'll look at the difference between those later on, and serous fluids, so fluids, things like peritoneal fluid, that type of thing, and I'll cover that later on. So the types of specimens that are routinely analysed by cytology, things like cyst fluid. So for example, many patients will turn up in a clinic with for example, a breast lump, which will be palpable, you can feel it through the skin, and sometimes that would be biopsied to find out what is within that lump, especially if that lump on ultrasound doesn't look like a fluid-filled cyst. And in many occasions these do come back as fluid-filled cysts. So anything that's a nodule that's full of liquid, we can stick a needle into there, suck out some of that needle and apply it onto a microscope slide to see what is in that lump or in that cyst. So many other parts of the body contain fluids that can be taken, particularly ophthalmic fluid, so aqueous, vitreous humour, that type of thing, synovial fluid from joints, serous fluid, so this is fluid around the heart, peritoneal fluid, also called ascites, and pleural fluid around the lungs. These can all be taken, particularly if we're looking for tumour in those particular sites. We can do bronchial washings, which involves passing a small amount of saline down into bronchi or down to the lungs, and then sucking that back up to see what that saline brings back. Urine sediments, quite self-explanatory. Usually a first void urine in the morning is centrifuged down to find out what cells might have been present, particularly if we're looking for detached cells from bladder cancer, for example. So I've mentioned fine needle aspirations, biopsying a cyst. There are fine needle aspirate biopsies where you insert a needle into what appears to be a small solid lump and suck out some cells from that, so they can be fine needle aspirate biopsies. Brushings would come under the heading of cervical swabs or cervical smear samples, or brushing cells off the surface of the cervix. And then finally we can have things like cerebral spinal fluid sputum samples that are coughed up. So basically all of these are fluids that will contain cells, and in many cases when we're looking for cancer, we're looking for an unusual cell type that shouldn't normally be there. Samples can be either fresh or more usually fixed. So fresh samples obviously are more high risk. They deteriorate very quickly within time and give poor morphology, and typically used to provide a very quick and immediate cytospin. Whereas fixed samples, better preserved, you get really good cell morphology. You can have solutions in there that do things like lyse red blood cells and really clean up a sample, which wouldn't be possible for just a fresh sample at a quick dirty cytospin. And these are also used for cytospins or some sort of variation of cytospins. So this is a cytospin which you may have used in a second year lab, and basically this is a small centrifuge, and this centrifuge takes a microscope slide. On the top of that microscope slide is a piece of filter paper with a hole in it, which represents that hole, that circle there, and then a funnel which fits directly over the top of the hole in the filter paper. You insert your liquid suspension of cells into that funnel, start the centrifuge, and that will centrifuge the cells down the funnel through this little hole, and the cells will then get deposited on the glass slide in a neat little circle where there's a hole in the filter paper, and then the filter paper will absorb the liquid and then encourage those cells to rapidly dry. So you end up with a neat little circle of cells on a microscope slide. So much cleaner than just smearing some cells on a microscope slide. So we have commercial kits for dealing with particularly fine needle aspirate biopsies and getting those onto a microscope slide without necessarily going down that cytospin route. So in these thin prep processing containers, what we can do is aspirate the sample with a needle and saline, take up some of those cells, and then transfer them into a preservative solution as shown here. And we can deposit the cells into these little canisters and then use these automated thin prep processing filters to separate the cellular material from the debris. And then by vacuum, cells are sucked up and captured onto a filter, which then can be inverted and pressed onto a thin prep microscope slide, and then the surface tension on that slide encourages the cells to adhere to the slide, and you have then got a very quick impression of those cells that have been taken out of fine needle aspirate biopsy, and you've very rapidly got them onto the microscope slide, having passed them through a fixing solution and separated out the cellular material from the debris. So I mentioned fixation in the last slide. Fixation is just a way of preserving the sample for as long as possible. This also kills the cells because what we're dealing with here is things like alcohol, formalin. We can air dry the cells, so we are killing the cells and also killing the high risk organisms that could also be in there. And basically if we are killing off all of the cells and all of the bacterium in there, but we're also often, if using things like formalin, cross-linking enzymes together, so basically there will be no enzymatic degradation of that sample. The cellular structures will remain intact, it will not become enzymatically degraded like a fresh sample would, and therefore the samples are stable for prolonged periods of time. So when we're dealing with histology, we tend to do formalin fixed paraffin embedded tissues where the sample, a lump of tissue is fixed in formalin, paraffin embedded and sectioned, and those are preserved long time for a very long period of time. The alternate to that is doing a fresh frozen sample where the samples are snap frozen in liquid nitrogen and then sectioned as fresh sections, but those sections have to be kept frozen until they are in some way fixed in the first stages of staining, and that fixation step is often alcohol. And after that point onwards, for a fresh frozen sample, that would be effectively fixed and stable on the microscope slide. Until something has been done such as alcohol or formalin fixation, the samples are prone to degradation. So for many fixation situations, alcohol is used, rapid, very quickly fix your samples, very inexpensive. maintains chromatin detail very, very well. There are some commercial solutions that contain formalin, alcohol and also red blood cell lysing agents, which can be very good, particularly for bloody preps, especially cervical preps. Whereas for a quick dirty prep, to have a quick look at something, air drying is possible. You can apply cells to a slide, allow them to air dry. There's no alcohol there, there's no health and safety implications, I suppose. But the problem with this is you can get artifacts. So you've got some nice chromatin detail here, whereas in an air dried sample you often get artifacts. The cells dehydrate, shrivel up, lose their normal morphology, which you tend not to get with a alcohol fixed sample. So alcohol fixation always gives much nicer preps. Air drying is sometimes necessary if you need to do a quick and dirty prep. Now in cytology, typically intact cells are applied to a slide, and that is quick and easy, but sometimes you might want to section through the cells, maybe to see if the membranes are staying positive for something, and you can't always tell that if you've got intact cells on the slide. It's nice sometimes to slice through a cell and be able to see a cross-section of the membranes, a cross-section of the nucleus. And this is possible for cytology, and you can do a cell block preparation. So in a cell block you would fix your sample in formalin, resuspend it in agar, and then what you can do is, once you've got something that is solidified, you can then process that cytology cell block like you would do for a tissue block, and then take sections through that what was previously a cytological sample, but you can now take sections of it. Now it's not like doing histology. You don't get tissue sort of stratified cell layers within a tissue like you do in histology, but you can cut through the cells in the same way that you would cut through cells and get cross-section of cells by histology. So just a few of the stains that you're likely to come across in cytology, and many of these you'll find in histology. Some of them are limited to cytology, others are routine in both histology and cytology. Probably the most widely used stain is HAEMATOXYLIN stain. We'll have covered that in histology, where whenever I talk about H&E, I'm talking about HAEMATOXYLIN and eosin, and this just basically stains the nucleic acids purple, so you can see all nucleated cells. So you can see here a cluster of nucleated cells in a blood prep. Probably the next most widely used stain is the PAPANICOLAOU stain, very widely used in cervical preps. We've got a nucleodide again, HAEMATOXYLIN, to stain the nuclei blue or purple, orange G to stain keratins, and eosin azure to give some sort of contrast on some of these sort of less keratin containing cells but have still got the squamous morphology. So in these you fix the samples and then stain them up with HAEMATOXYLIN and with this PAPANICOLAOU stain combination, and this is what we see here. So in the second half, in video 2 from this session, I will take you through cytological staining in more detail, but basically what we've got here are fairly large squamous cells containing keratins, which is why they've stained up in that particular way. We've got small nucleated cells in there. What we're looking for in cervical cancer is a transition from these large flat squamous cells into much smaller, rounder, larger nucleus compared to cytoplasm. So there we're looking for cellular morphology changes. A larger nucleus, smaller cytoplasm is typically what we're after, and this combination that highlights the nucleus, highlights the keratins, is ideal for that purpose. There's a link there if you want to click on that to see some more cervical examples. So here's some cell types that you're likely to come across in different cytological samples, and highlighting also some cells that you might think look abnormal. So here are these are transitional cells through the cross-section of the bladder. The very, very surface cells, superficial transitional cells called umbrella cells on the very outer lining of the bladder, are sometimes multinucleated. So this is one of those things that you see on a a prep and you think, oh, multinucleated cell, that's abnormal. Sometimes these are perfectly normal. And we've got some high-grade transitional cell carcinoma from the urinary bladder, and here we're seeing cells which have quite variable nuclei, prominent nucleolus, that seem to be growing in clusters rather than just individual cells which have detached. So that's a sort of feature that we'll be looking for. It's a particular variation from cell to cell and prominent nucleoli, very small cytoplasm. And we sometimes see this with squamous cell differentiation. So squamous cells are large, flat, protective cells, squamous coming from scaly, and they stain positive with for keratins, as we've just seen on the Papanicolaou stain. So you can see here you've got a mixture of cell types, some squamous, some epithelium, some very, very small, probably lymphocytic cells as well in there. So a whole mixture of things within that sample. So moving on to respiratory cytology. Now in respiratory cytology, we're sometimes looking for infectious agents. I'll be focusing on sort of non-infectious cytology here. We're typically looking for tumour detection. So patients who are coughing up blood in particular is very high concern, and those samples can be used to see what is in that material that is being coughed up, and if there are clusters of epithelial cells in there, then obviously that would be a severe red flag. So sputum is okay, but it's low sensitivity, and I suppose it really depends on what is coughed up at the time where you take that sample. There are more specific ways, and we can do endobronchial ultrasound, and then we can use that to guide a fine needle aspirate biopsy into tissues around the lungs. Sometimes if we know that there's tumour in the lungs and we want to look for the potentially affected lymph nodes, many of the lymph nodes are accessible by fine needle aspirate biopsy, either down the trachea or down the esophagus, and I'll show you that in a later slide. Now, if present, we can often detect tumour cells in serous effusions. When I say serous effusions, pleural fluid. If we can get hold of that pleural fluid, we can find sometimes little clusters of tumour cells looking very abnormal. We wouldn't expect to see any cells like this in pleural fluid. And this slide just shows the various routes for which cytology samples of lymph nodes can be obtained, and this is showing the lymph nodes in and around the lungs. So these up at the top are accessed by endobronchial ultrasound guided transbronchial needle aspiration, which is a bit of a mouthful. These down at the bottom are accessed via the transesophageal route. These in green can be accessed by both routes. So there are loads of lymph nodes around the lungs and around the associated esophagus and bronchial regions, which can be accessed by ultrasound guided fine needle aspirate biopsy. And this is just shown at a much more accessible site, shall we say. So fine needle aspirate biopsy can be done under ultrasound guidance if it's a slightly deeper site and we are injecting a needle into the lesion, the tumour, the lump, and inserting that needle and then trying to withdraw a small amount of cells into the needle, into some fluid, which then can be put onto a microscope slide. So we can use fine needle aspirate biopsies to take small clusters of cells from either the primary tumour or from lymph nodes, and both of these are thyroid carcinomas. So this one on the left is a fine needle aspirate biopsy of the thyroid tumour itself. So a small cluster of cells have been removed, and what we haven't got is the tumour cells in the full normal arrangement within that tissue. We have got a cluster of cells which has been detached, that has been embedded in a cell block and then stained up for cytokeratin 19, showing these very positive cells here. Here we've got some clusters of cells that have come out of a lymph node fine needle aspirate biopsy, and also put into a cell block and prepared in the same sort of way, sectioned and stained for cytokeratin 19. And again, you can see these clusters of cells within the lymph node, and you shouldn't really see cells with cytokeratin expressing morphology in the lymph node. So this will be diagnostic for metastatic cancer spread to the lymph node, whereas this can be used to investigate the cell morphology and the expression of cytokeratins in tissue from the thyroid itself. Okay, so that's just about the end of the first part of the lecture on non-gynae cytology. And I thought I'd just put this slide in because maybe it should have been in earlier. It shows the various serous cavity efflusions that I mentioned earlier, so the pericardial cavity, the pleural cavity, and the peritoneal cavity. Okay, so that's it for non-gynae cytology, and the next video that you'll have is on gynecological cytology.